Reminder, you need to rule out red flags. For example, if a patient complains of low back pain, you need to rule out cauda syndrome. Ask about saddle anesthesia during the physical exam. Can you feel sensation on the inner surfaces of your thighs? Can you feel sensation on the buttocks? You need to evaluate for any incontinence. Ask the patient, have you been urinating involuntarily? Have you been having any bowel movements involuntarily? Also with low back pain, you need to rule out herniated discs. Ask about radiculopathy. Does the pain radiate anywhere? Through the neurological exam, you can assess L4, L5, and S1. You can ask the patient to do heel walking, assessing L4, or toe walking, assessing S1. Or you can prefer to check patellar and Achilles reflexes. You can also assess sensation to light touch bilaterally, at the same time comparing side to side. You can also assess muscle strength, again comparing side to side.
So let's say I evaluated this patient. Let's say I screened him using the hospital screen. And I found that the area of greatest restriction, things that aren't bouncing, there's not a lot of motion, would be in the lumbar region. I can have him sit up and I can do a segmental diagnosis, or I could state that he has hypertonic paraspinal muscles on the left or hypertonic paraspinal muscles on the right. So let me have him sit up. And so just to show you guys, let's say during the hospital screen I'm palpating, this is the area that I find to be most restricted. The paraspinal muscles all along here. This one's a really, really tight. And I'll tell the patient, talk in layman's terms, be like, wow, sir, this is really, really tight. Your back muscles over here. Do you have any tenderness? Are they achy? Things like that. Remember, when we're evaluating the patient, we're checking for TART, right? Checking for tenderness, any kind of asymmetry, and he does definitely have asymmetry here. Any kind of restriction, any tissue texture changes. So remember, on the back of your head, use TART to be able to describe your findings on your objective portion of the SOAP note. So a treatment that I can do, if I'm not doing a segmental diagnosis, a treatment that I can do to treat hypertonic paraspinal muscles that you can write in your assessment is paraspinal inhibition. So what I usually do is treat the patient supine, but just to show you guys, my hands are going to be laying on the table like this, but we're going to be grabbing those paraspinal muscles as much as we can, squeezing up and letting the patient's weight fall in, and we're kind of holding those paraspinal muscles until we feel a change, we feel some softening, feel a little bit of a release. So that would be paraspinal inhibition. So you can put that in your plan of the kind of treatment that you used. So let me have you lay on your back for me with your head over here. Great. And remember, adjust the table appropriately. Make sure the chair is adjusted appropriately. So I'm just going to put my hands here. If there's anything really uncomfortable, you let me know. And so as you're here with inhibition, we're kind of holding it. I can tell the patient, have some deep belly breaths for me. Great. And in that case, we use like some respiratory assist, This can take about like 30 seconds, and we're just going to move up and down that lumbar region. So I started at about like L1, so we're going to move down. And there's a little bit of a change, a little bit of softening, so I'm going to move down a little bit. breaths for me. And this feels okay? So when they come in with a complaint, remember you have multiple things that we can do to help the patient. And so because he had all this hypertonicity in the lower back and possibly complaining of low back pain, and there we have a huge softening here actually on the left, so that's really great. Another technique that's really, really good that I used often during third year, and it's really great, is if we check and see 12th rib, the motion and mobility of the 12th rib, treating the 12th rib, if restricted, is really great because we have the diaphragm attaches at the 12th rib, psoas attaches at the 12th rib, and quadratus lumborum attaches at the 12th rib. So if you think about it, it's like a really great treatment. So I'll have the patient sit up just so you can see where my hands are going to be. Remember, we need to diagnose and be like, there's restriction at the 12th rib on the right side or on the left side. So make sure that you have a diagnosis before going ahead and treating it. But if he did have all this hypertonicity, that also counts as well because quadratus lumborum lies there. And so you can automatically go and treat the 12th rib. So just if you wanted to be thorough, you can check 12th rib just like this and see if there's any restriction in motion. And there's a little bit on this side. Definitely more than this side, but because of this hypertonicity, I think it's valid that you can use this as a treatment. So let me have you sit up with your back over here. So remember, finding the 12th rib is really, really easy. So I'm going to follow the 12th rib up. And so as he's laying supine, I'm going to just put one hand here, kind of on the rib angle, and put the other hand here, and I'm going to push anteriorly and a little bit laterally. And again, we're going to have the patient kind of melt into the table. Ask him to take a few belly breaths. Make sure he's using his diaphragm so there's some respiratory assist. And we're just going to hold it until we feel a release. And so it's kind of like an inhibitory treatment for the 12th rib. So let me have you lay on your back with your head over here. Okay, so after we've treated the paraspinal muscles with inhibition, we can go ahead and treat the 12th rib. And so as we're doing it, you're going to find the 12th rib. Remember, we're palpating up, anteriorly, and laterally. And I'm going to bring the other hand and help support that. And let the patient's weight onto the table kind of bring some force down. Is this okay? If there's any kind of tenderness, let me know, or a lot of discomfort, just let me know and we can stop. So as we hold this, this is a good time for you to ask your patient any questions you may have forgotten. This is a good portion of like your humanistic. So if you didn't forget anything, if you forgot to ask about diet, caffeine intake, or family history or anything like that, you can ask them, and waiting for this muscle in the back to soften or to relax a little bit on your hands. Also, it's a good time, you can ask them, are you from Philadelphia or Chicago, and you can just chit chat. And so while I'm holding this, you can also take the opportunity to talk to the patient about what exactly it is you're doing. And you can tell the patient that we're helping to restore motion to the muscles, we're helping to reset the muscle. If it's really, really contracted, really, really tight, we're going to help it relax, to bring proper motion to that rib, help you breathe better, help you take better deep breaths. And I can feel it soften under my hands. And for 12th rib treatments, I would usually do both sides. And so remember, bring the chair around. If you can't bring the chair around, you can ask the patient. Let me have you actually sit up and put your head over here and lay on your back for me again. And you can treat the other side, right? And I'm going to find that 12th rib again. And again, sir, if there's any kind of tenderness or if the discomfort's too much, you let me know. And again, I'm putting both hands under, pressing anteriorly and laterally, and I'm going to hold it until I feel a softening, or a change, or a release. we're restoring blood flow, helping waste removal, helping bring oxygen to those tissues, to those muscles. There's a lot of different things that you can talk to patients about. And remember, use layman's terms. Don't use any kind of medical terminology. So for low back, a lot of things we can think about is psoas hypertonicity. And so one of the tests that we can do, so once this treatment's done, again, you're going to reassess, right? So reassessing, you can redo the hospital screen for the paraspinal muscles. You're just going to go right back and you're going to reassess and see if the motion has changed. And it's actually a little bit different. It's not 100%, but there is some change. This might be a chronic issue that he has. For the 12th rib, again, you can kind of reassess and see that mobility, and that actually got a lot better on this side. Yeah? So for the psoas, we can do the Thomas test. And this is something that you can actually document and see if it's the Thomas test is positive or negative. And so I'm going to tell the patient, hey, can you grab this leg and hug it to your chest, just one leg at a time? And I'm going to look and see over here and see if the leg lifts up at all. And there's very, very little. Let me have you squeeze the other leg up to your chest for me. And this one's a definite positive, yeah? So if I had to treat one, I would treat this side, and I would say it's a right positive Thomas test. So right psoas hypertonicity. And so to treat this, we're going to treat it like we treat a posterior innominate. So we found that the Thomas test was positive on the right, so I'm going to ask the patient, can you scooch over and be right here at the end of the table point? Great. And so I'm going to put this leg into the barrier. I'm just going to bring your leg out, remember, into extension, and I'm going to stabilize here at the ASIS. And we're going to do some muscle energy the same way that I would treat a posterior innominate rotation. So I'm going to have the patient, can you push up for me here? 3, 2, 1. And just relax your leg, and I'm just going to bring it further into that extension. Further off. That extension. Further off of the table. Into that barrier. And again, can you push up here for 3 seconds? 3, 2, 1, and relax. And again, further into that extension barrier. And again, push up for me. 3, 2, 1. And relax. You can do a little bit of a passive stretch. Assist them in bringing the leg up. And again, we're going to reassess, doing the same thing that we did to diagnose. So hug this leg to your chest. A little bit better. And bring it down. And again, we'll just assess the other side just to see. And tap this one. And now this one, you can definitely do the treatment on that side if need be. Okay, so another approach to low back pain, or if you find, when you find the area of greatest restriction in the lumbar spine, you can do the segmental diagnosis that you were taught a lot in school and in lab. So if I felt restriction here, either when I did the style screen or when I did the hospital screen, I'm going to palpate down. And when you do this, be confident. You don't want to mess around too much and just be like, is it this, is it that? Be confident if this is the way that you're going to diagnose. And so I'm just going to go down. I'm going to try to see and feel which one of these transverse processes feels more posterior, and that would indicate that that segment is rotated to the right, or if it's on this side, rotated to the left. So I feel this one definitely. Yeah, right here, actually, I feel that this one is more posterior on the left, so he's rotated to the left. And remember, you should be about 2 finger widths from that spinous process, so we're at the transverse process. And when I tell the patient, to flex forward. I'm not going to tell them, please flex forward or extend back. I'm going to tell the patient, can you tuck your chin to your chest and bend forward for me? And come back up. And stick your belly out for me. And come back up. And he actually gets worse in extension and better in flexion. So he would be FRS left at about T11, I would say. And if you're off by one segment, that's okay. So he's about T11, FRS left. So remember, that's my diagnosis. So when I go to treat him, I need to make sure that it's appropriate. So when I go out and I write my SOAP note, and in the assessment portion, I write FRS T11, FRS left. Make sure that in the camera, we are doing the proper treatment for that segmental diagnosis. Many things you guys can do here. You guys can do muscle energy. You know, we can put him into the barrier, have him work into the freedom, all that. Or we could do FPR, or we can do still technique. And just to show something different than muscle energy, we'll do some still. So if he's FRS left, we're going to put him indirect. We are going to add compression, and remember, when we're adding compression, we're not going to add compression here. We're going to make sure that when we add compression, that we're going to make it all the way down and localize to that segment. Take him indirect, we add the compression, and then we take him into the barrier, which would be ERS right. Bring him back to neutral, and we would reassess. Remember, a lot of these patients have had OMM done on them, so they know what certain treatments should feel like, they know how much pressure, how much compression they should be feeling. So make sure you're localized, make sure you're comfortable with the treatment you're giving. Don't give a sham treatment. So, is it okay if I put my arm around you? Sure. Okay, cool. Actually, let me put the table a little bit lower for myself. And it's okay, you walk around, you do all these things, and it shows that you know how to appropriately localize the patient and make it easy for you. And so I'm going to put him into slight flexion. So can you bend forward a little bit for me? Great. And I'm just going to hold you here, okay? And so I'm going to side bend him. Rotate him at that segment. Now, with my arm, I have my upper arm and my hand here, and we can add compression to that segment. And then I'm gonna bring him to side bending, rotation, and I'm gonna help stick his chest out. And bring him back to neutral. And again, palpate again those transverse processes. Tuck your chin to your chest and bend forward for me. And come back up and stick your chest out, stick your belly out. Great, and it definitely got a lot better in extension. That transverse process definitely went in than it was before. And that would be segmental diagnosis, segmental treatment. You have many options here.